Okay, I'd like to do a little bit of re-review on the hip, because that is the most difficult subject in orthopedic MRI. Not that big a joint, carrying a huge area, ball and socket joint, and I find that most people have difficulty understanding the concepts of impingement. Now, many hip problems in adults are related to unrecognized mild developmental dysplasia of the hip. And when I say many, I do mean many. The acetabular roof may be just slightly vertical. There's cup under coverage. In other words, the cup isn't completely covered by the acetabulum, and rarely the ligamentum teres is absent. For instance, here's the ligamentum teres. So let's cover some anatomy for a moment. The ligamentum teres has two heads. It has an anterior pubic head and a posterior ischial head. And you should look for it in every single case. It should be part of your search pattern. The labrum may have a very tiny notch in it, no more than a fifth of the depth of the labrum. The labral sulcus is found down here in the anterior inferior quadrant, not up here. So when you start to see razor-like fissures or something you think is a sulcus that's deeper than, say, 10 or 15%, it's going to be a labral tear. That doesn't mean it's symptomatic. The hyaline cartilage on both sides is going to add up to about 3 millimeters throughout the hip. You're also going to see a ridge or an area of irregularity where the triradiate cartilage comes together, and that is known as the stellate crease. Now, the ligamentum teres can tear, it can avulse, or it can be completely congenitally absent, which is associated with varying forms of hip dysplasia. And what it is, the hip starts to float out laterally. And here's a gross specimen showing exactly just that. I illustrated for you yesterday as a quick review what measurements you need to take to form an alpha angle. I hadn't shown you an abnormal one yet, but I will. Here's a bump, and instead of the angle going to this head-neck junction, it goes to the first dip from the best fit circle of the femoral head, which is here, producing an alpha angle that is over 60 degrees. This one's 65 degrees, and this particular one comes from the work of Chris Fearman from Switzerland. In order to make that alpha angle measurement, it should be done obliquely. Here's a normal one. Here's an abnormal one. And in terms of anterior fissures regarding the labrum, it is very common in normal individuals who are adults to have posterior labral tears all day long, just like we see them in the shoulder. They may be minorly symptomatic or they may be asymptomatic. It's the anterior ones that are symptomatic, and particularly the anterior traumatic ones, the ones with cysts, and the ones with arthritis right in the area of the labral tear. Now, anterior superiorly, you should not see a sulcus. You should learn to differentiate the space between the capsule and the labrum right there from an actual tear, which is in the substance and typically between the labrum and the adjacent acetabulum and hyaline cartilage. Now, what is femoroacetabular impingement? It's basically abnormal contact, especially in wide ranges of motion. It's more severe in internal than external rotation, and it can be either cup dominant, in other words, the cup's too shallow, cam impingement, cup too deep, pincer impingement. Or it can be femoral dominant because the femur is too small, or more commonly, they have coxa magna, the femur's too big. Here are some of the provocative tests. People who are impingers don't like this position. This is called the flexion adduction internal rotation test, where actually this is the flexion abduction external rotation test, the Faber test. But when you cross your legs over one another, that is the internal rotation test. and impingers don't like either of them. But of the two, I can tell you because I have it, the internal rotation test where you cross your legs one right over the other with your knees almost touching is the most uncomfortable position. That position. That hurts much more than that does. And I can tell you from firsthand experience. Impingers have restricted flexion, and we'll see why in a minute. Now, there are two basic types of cam-type impingement, but there is quite a bit of overlap. In CAM-1 impingement, the patients have a shallow cup with asphericity of the head-neck junction, a wide neck. They may have a bump. They may have a cyst. And a pincer-type impingement patient has a deep cup, sometimes with protrusio acetabuli or coxa profunda. The femoral head is normal or small, and the neck is usually tapered. So they do not have a wide neck. They do not have this phenomenon of asphericity. Here's what it looks like. Here's a cam impinger with a bump and lack of sphericity. Here's a pincer impingement with a very tapered neck. The cam impingers have shallow cups. The pincer impingements have deep cups, and especially anteriorly, the acetabulum protrudes too far laterally, produces femoral retroversion. This may break off and form an ossicle. Now, there are overlaps of both, but because of this retroversion effect, there is extensive delamination, chondromalacia in the back in pincer impingement, whereas there is a small abrasion in the front in cam impingement. So let's summarize again. Cam impingement, asphericity, not. Retroversion, pincer impingement, not. Shallow cup, cam impingement, deep cup, pincer impingement. Chondromalacia and abrasions in the front, cam impingement. Extensive severe chondromalacia in the back, pincer impingement. Undercovered, overcovered. Look what happens when you go into internal rotation in either of these phenomena. But especially in cam impingement, you abut the bump cyst complex against the labrum, you wear the labrum out, you tear it, and you eventually develop chondromalacia. Here's an example of somebody with a friction contact point in flexion and external rotation, right there. The joint space is narrowed, but look how fat the neck is on this side. So this patient is developing friction impaction like that case that I missed that I showed you yesterday with the tiny spur. Only this one we picked up because there was a spur and there was also a fat neck with a bump cyst complex. So this one was a lot easier. I'll show this movie to you later, but it will work because we have the entire movie here. So here is another example of cam impingement, but in a different projection. It's in the coronal projection. Once again, a bump cyst complex, but you could acquire that, right? With a spur, just like we did yesterday, the one I missed. So a tiny spur right there will have the same effect as a dysplastic bump cyst complex. Now, this configuration is known as the pistol grip deformity. Now, here's somebody that doesn't have a bump, but they're not really tapered. Yet they have this thing called a herniation pit, which Toddy and Murphy described in 1990 in the Yellow Journal, which I said half the articles are useful and half not. And they said, it's a herniation pit. It's an incidental finding. It's of no consequence. It should be differentiated from an intraosseous ganglion. Well, guess what? It is an intraosseous ganglion. It's a sign of cam-type impingement. Just didn't know it at that time. So the article was completely off base. Something else I like to do when I assess my hips is I like to have radial images so that I can look at the labrum perpendicularly in every projection. Now, as mentioned, many professional athletes are going to have abnormal alpha angles. So the alpha angle, as many as 40%, is not a way to diagnose impingement syndrome. It's a supplementary tool only. And most impingers are not pure cam impingers. They're not pure pincer impingers. 70% are mixed impingers. But as mentioned, many young patients have big, broad, fat femoral necks. I also mentioned to you yesterday that when you're looking at labral tears, 10% of these labral tears will only be seen in the sagittal projection. Let's take this 16-year-old Division I NCAA college prospect. He's 155 kilograms with the inability to develop a leg drive or power. Rule out sports hernia syndrome. No hip pain. Is he an impinger? The only finding was this: slight asphericity, a little bit of a bump, no click, no hip pain, and this. Now we are in the anterosuperior quadrant. You don't get deep fissures and sulci up high. Those are down low. So we said, that's a tear. His orthopedic surgeon said, I don't believe it. He's got no hip pain. We said, believe it. He said, I want an arthrogram. He said, you don't need one. He said, I want an arthrogram. So we said, okay. We put the contrast in, and there is your labral acetabular detachment, the most common form of labral tear in the young individual, and that's why he couldn't get his leg drive. Here is the rest of the non-contrast study. Oh, we see it. There it is. There it is. It persists. It persists on slice after slice after slice, a chondrolabral and osseous detachment, the typical young person tear. And yes, that little wispy thing is still part of the tear going posteriorly. We didn't need contrast at all to make the diagnosis. Here's another individual with cam impingement with a macerated labrum and another sign of impingement. Not this sign, asphericity with a little bump. Not this sign with degeneration of the ligamentum teres, but this one, loss of the typical hyaline cartilage signal on a heavily water-weighted sequence. It's dark. That's a sign of altered proteoglycan and glycosaminoglycan milieu. It's desiccating. So that is what an abrasion looks like, the so-called inside-out abrasion associated with this complex labral tear, and he's starting to strip the iliofemoral ligament from the lateral acetabulum. I think you'll get a more full understanding once you see the video, which I hope to show you. FAI2, or pincer-type impingement. There's a whole bunch of signs described with pincer-type impingement. I've got them listed for you here. Let's have a look. One is coxa profunda, where the interacetabular wall protrudes medial to the ilioischial line. Protrusio acetabuli, where the actual head protrudes medial to the ischio-ilial line. Then we've got the crossover sign, which I'm going to show you in the axial projection, a little hard to understand coronally. The posterior wall sign, where the center of the femoral head is located outside a line drawn between the superior and inferior bony cup. And then a large ischial spine as another sign of impingement. And here I've got them defined for you. Coxa profunda, floor of the acetabular fossa overlapping the ilioischial line, protrusio acetabuli, medial to the ilioischial line is the femoral head. Then the crossover sign, also known as the figure of 8 sign, in which the superior acetabulum protrudes to the midline more than the posterior acetabulum. So let's say this is superior, this is anterior, I apologize, anterior, posterior. And then as you start to go down, they switch positions. That's the crossover sign. And the posterior wall sign, very self-explanatory. And the ischial spine sign, also very self-explanatory, protruding medial to the pelvic brim. Let's look at some other structural considerations for labral tears. Everybody knows about the bump and the cyst. Everybody knows about the pistol grip deformity, but not that many people know about coxa, in which you have more of a right angle configuration of the hip, something that looks like this, so-called femoral antitorsion. So it kind of has a right angle as opposed to coxa, where things are kind of straight up and down. Under coverage, super common. One of the types of low-grade developmental dysplasia of the hip, big femoral head, or coxa magna. Now, for years, we used to talk about os acetabuli. You know what an os acetabuli is? It's a broken ossicle, because the anterior labrum sticks too far out, and then it breaks off. It's that simple. And it becomes pretty well corticated. So ossicles or broken spurs are very common. Now, impingement can be acquired. We've broken it down into cam and pincer, and I've got this nice algorithm for you on MRI online. But you can also have primary and secondary impingement. You saw secondary impingement yesterday, the one I missed. Person developed a spur on 2 sides. They were kissing spurs. And every time he brought his leg up and externally rotated, severe pain. Now you know, you've been around a long time, when the first person that's ever interviewed you for a job after your fellowship calls you up and says, "Can you look at my son's MRI?" So I was honored by that, of course, but I was also humbled by it because it meant I'd been on the earth a while. Her son was an ultramarathoner, one of these guys that ran 80 or 100 miles. Look at his plain film, undercovered bilaterally. Look at his MR. He is attempting to keep the hip in place by hypertrophying the acetabulum, but it didn't work. He broke this ossicle and labrum on the right. He's stripping the capsule. He's developed an extra-articular paralabral cyst. He's got an effusion. He's got a pistol grip deformity. He's not symptomatic on this side, even though it looks almost equally as bad, but he will be. Now, you can also have intrinsic and extrinsic impingement. What is intrinsic impingement? It's when something in the joint pushes the femoral head anterior and upward, like pulmonaric fat, a plica, a body, some object inside the joint, like this one right here. That object is pushing the femoral head up. He's also got a little bit of coxa magna, and that has resulted in this shallow but definite labral tear, because you don't get sulci in the superior quadrant. You get them in the anterior inferior quadrant, and he's got a bump cyst complex to complement his impingement that is intrinsic. So he's got both extrinsic and intrinsic impingement, and he has an erosion or an abrasion in the acetabular roof. Here's another one, pistol grip deformity, bump cyst complex. This is a dysplastic type. Here's one that's acquired, little spur, big spur, same as the one I missed the other day. So for FAI2, all you got to remember is darn that FAI, because it hurts more than FAI1. The cup is deep. there's tremendous arthritis. There's retroversion, and the neck is narrow. So don't forget about the mnemonic darn. There is a broken ossicle. No, it's not a congenital os acetabulare. He's got the crossover sign. You're up high. The anterior labrum should never protrude lateral to the posterior labrum. And then as you go down, this shrinks back. So they crisscross. This gets more lateral. This gets more medial. That's the crossover sign. This one broke off in hip flexion to create that ossicle. Another rule of thumb is the center of the femoral head should pretty much line up with the posterior bony acetabulum. Here's an example of FAI2, pincer type impingement. Now, you don't often get them this pure. This elongated anterior wall of the acetabulum produced retroversion. It broke off. The patient has a deep cup. They have these claw-like, crab-like, pincer-type spurs. The arthritis is massive, especially in the back. Look posteriorly. There's no cartilage whatsoever. That is all fibrous tissue. Yes, the entire joint is involved, but look how deep these spurs are grabbing the acetabular head. So the surgeon's dilemma: am I doing a joint replacement? Am I going to do a femoroacetabuloplasty? Well, how do you make that decision? You have to have good hyaline cartilage. Is there something else temporary you can do, like inject lubricant or Synvisc? But the key to making this decision is, what is the status of the rest of the joint? And then it's helpful to know, what is the dominant impingement subtype? Is it more cam? Is it more pincer? And how good does the other hip look? And how good does the ipsilateral knee look? It doesn't do you any good to fix the hip and then have osteoarthritis of the knee. So if I'm going to have a patient get a joint replacement or get a femoroacetabuloplasty, I always scan the ipsilateral knee. Now, assessment of hyaline cartilage is tricky. So let's do a quick vignette on it, and then we'll get into our cases. Oh, that's a scary slide. That's the ProScan grading system that's adopted from the International Orthopedic Society's grading system. Now, most of you are familiar with the Outerbridge grading system for hyaline cartilage, which is perfectly fine to use. Grade 1, intrasubstance proteoglycan change. Grade 2, a blister. Grade 3, full thickness ulcer. It can be a crab meat ulcer, it can be a defect. Grade 4 goes through the subchondral plate into the bone. That's fine to use. But if you look at this system, one thing it does is it tries to assess depth. So I like to try and decide less than 50%, greater than 50%. If it's greater than 50%, has it penetrated the osteochondral plate? Now, when you have really high resolution imaging, you can even get a little more specific than that, but it's often unnecessary. At the bottom of this slide right here, you see something called stratification. What does that mean? That means that the cartilage signal is stratified from deep to superficial. Or in other words, it's going to be darker, deeper, and lighter, more superficial consistently. It's going to shade up as you go more superficial. And that's why we may sometimes do cartilage mapping in patients who are candidates for femoroacetabuloplasty to see the internal health of their cartilage. So when I'm looking at a cartilage lesion, I look at the length, the width. Is it weight-bearing or not? How did they get it? Did they get it from an acute trauma or a chronic trauma? What's the depth? How am I going to grade it? What's the shape? Is it vertical? Is it broad? Is it thin? Is it crab meat? Is it a blister? Can I give it an age? Does the patient have OA? Do they have spurs? Is there synovitis and inflammation? Is there a known history of trauma? And what pulsing sequences am I going to use to locate it? So here is the phenomenon of stratification, showing you the deeper radial layers that are darker. They're broken down into the radial tide mark, the calcified zone, the subchondral plate, and then you get into the cancellous bone. So if you've gone through here, that's a whole different animal than if you're in here, in the middle layer, which is a little bit grayer, and then the superficial layer covered by synovium, which is a little bit brighter. Now, the cartilage matrix is actually formed in arcs, so it's parallel. So whenever you have this phenomenon of parallelism, the more parallel things are, guess what? That changes signal. That participates in the anisotropic effect. So the parallel areas are radial, darker. The less parallel areas are lighter. That's why you have stratification in the hyaline cartilage. Now let's take the patella as an example. Here's a high-resolution 1024 matrix. It's a T2 FSE with a small field of view. That's gorgeous. Look at the lighter signal of the superficial layer. Now this would not be a sequence I'd use for stratification, but it is a sequence I use for superficial chondromalacia. See that little area of fraying? That's just wear and tear. That's called living, existing on the earth. And then we've got the medial patellofemoral ligament and the lateral retinaculum and the medial retinaculum and some more superficial components of the medial retinaculum. But yes, the MPFL is seen as a distinct structure. So here's some stratification. Darker, deeper, lighter, more superficial. What's that dark thing? That is the free edge of the capsule. We have an apex, a lateral facet, a medial facet, and an odd facet with a normal parapatellar plica. And there are about 6 different types of plica. We don't need to discuss them today. When you have altered signal in the cartilage with change in proteoglycan milieu and a blister, then you have an outer bridge grade 2, and when you have full thickness depth lesions that are either a defect or crab meat, that's a 3. When you go through the subchondral plate and you're saying, well, I don't see that, that's because it's a T2. The T1 is better for it, but it does go through the subchondral plate, and it did right here on the associated anatomic cadaveric image. And I'll have many T1s like that to show you. So here's the phenomenon of stratification. What did we do here? This comes from the work of Potter from the Hospital for Special Surgery in New York. I've got many of these, but this is a pretty one, so I tossed it in there. And it shows the T2 relaxivity of hyaline cartilage. So what you do is you get a TR and then a TE at 20, 40, 60, 80, 100, 120, 140, and so on. And you measure the T2 relaxivity of that tissue. You make curves, pixel by pixel. The computer does it for you, but you've got stratification. The relaxivity is shorter in the deep cartilage, and it is longer in the more superficial cartilage. When you have OA, things become inordinately disorganized. Let's skip over this advanced grading system for hyaline cartilage disease. You'll find this on MRI Online, showing you all the zones of the cartilage and which zones are affected by which grade.